Myself, Dr. Jibran Ahmad presents to you Simply Pathology, and today we are back with a very important session. As you can see, today we are going to discuss a very interesting topic, that is minimal or molecular residual disease, also called as MRD. Now this question is very commonly asked in the exam, and especially it is asked in paper number 3 as a part of hematology or paper number 4 as a part of recent advance. Okay, it can be framed as both a long answer question as well as a short note. So basically, what are the points or what are the contents that we are going to read today? So first we are going to understand about the definition of MRD, followed by the basics and the introduction to MRD. Then the methods of detection of MRD, very important. It is not given anywhere, and whatever recent advances that has been given previously, they are very old, like 10 to 15 years old. So this part has been completely updated and it has been introduced in a very easy to understand manner, so that you can completely finish this topic within 1 hour. Okay. Then we are going to see the clinical significance and the applications of MRD. And after this, we are going to go into the specifics of MRD in acute myeloid lymphoma, acute myeloid leukemia, acute lymphoblastic leukemia, and chronic myeloid leukemia. Okay. So the question on MRD can be framed in various manner. It can be a generalized question, like they might just give you MRD, just MRD can be asked to you, a 10-mark question. So in that case, okay, in that case, you just have to write about the definition, introduction, basics, method of detection of MRD, and the clinical significance. That's it. Okay. Or the question can be MRD in acute leukemia, or the question can be MRD in leukemia. In all these three conditions, you can see it is quite generalized question. In case the question is generalized, you just write about these 4 things: definition, introduction and basics, methods of MRD detection, along with clinical significance and applications of MRD. That's it. So when the question is generalized, you have to write it in a generalized manner. Suppose they are asking you about MRD. They are asking, the question is define MRD, okay, the methods of detection of MRD with a specific emphasis on either acute lymphoblastic leukemia or acute myeloid leukemia or chronic myeloid leukemia. If they are giving you, they are emphasizing on any one type of leukemia, in that case only you have to write, okay, a little bit extra on that, okay, stressing a bit on that. Maybe, out of 10 marks, 3 marks are allocated to either of them, or these might be asked to you directly as a short note. In that case, you have to write a bit about the definition and introduction and basics, and just enumerate the methods of detection of MRD, and you directly go into the details of either one of them. Okay. So via this particular topic, we are not only discussing one LAQ, rather we are discussing 1 LAQ and 3 short notes. So 1 long answer question on MRD plus 3 short notes, okay, are being discussed via this particular lecture. Okay. So without wasting any time, let us begin today's topic of discussion. So coming to the definition of MRD. So what is MRD? MRD refers to the lowest level of disease which is detectable in patients who are in complete clinical remission, CR, by the most sensitive methods which are available, measured by the most sensitive methods which is available. So I am repeating once again, MRD refers to the lowest level of disease which is detectable in patients who have received some form of treatment and now they are in complete clinical remission. That means they do not have any clinical sign symptoms, and which is measured by the most sensitive method which is available. Okay. This is one definition. Or another definition is, MRD refers to a disease that cannot be detected by conventional light microscopy of blood or bone marrow in patients who are in complete clinical remission with no disease symptoms, the malignant cells being detected by only very sensitive immunological or molecular techniques. So in short, the basic idea about MRD is to check whether after a treatment, whether after one treatment, okay, suppose you have got one treatment and after that you do not have any clinical sign symptoms. So in that situation, if I take that patient's bone marrow or blood and if I check via the most sensitive technique whether I can see any residual leukemic cells or tumor cells or no. That is what is MRD, minimal or molecular residual disease. Okay, I hope this is crystal clear to each and everyone. Coming to the introduction, MRD acts as an important biomarker for clinical diagnosis and subsequent treatment of cancer patients. It is essential for assessing the risk of relapse, optimizing or modifying therapeutic strategies. Suppose after a person has received a treatment and you have measured the MRD, and if they are MRD positive, so you have to either intensify or you have to change your treatment strategy so as to obtain relevant clinical outcome. Okay, risk stratification of patients. So you have given one treatment to 3 acute leukemia patient. Out of 3 patients, 1 is MRD negative, 1 is having intermediate levels of MRD, 1 is having very high level of MRD. Okay, one is MRD positive, 1 is MRD negative, 1 is MRD in between. So those 3 patients will have different risk of relapse. So measuring MRD helps in risk stratification of the patient. Gauging efficacy of the therapy. Suppose a new treatment has come into the picture for acute leukemia, and that new treatment I have introduced in a subset of patients after taking their consent. So after giving the treatment, how I am going to see whether the treatment is working very nicely or no? Then after the remission of symptoms, I will go for MRD. Then if it is MRD positive, that means the treatment did not work. If it is MRD negative, that means the treatment worked. So MRD is essential for gauging or measuring efficacy of treatment and also to assess the patient outcome. Absolutely, any patient who is MRD positive, they will have a bad prognosis, and any patient who is MRD negative, they will have a good prognosis. Okay. So to understand more about MRD, you first have to understand the management protocol of leukemia. So leukemia treatment, it occurs mainly across 2 broad phases. The first phase is the induction therapy phase, and then after that any phase which is coming, it is called as post induction therapy. So suppose taking the example of AML, okay, in certain AML we give just chemotherapy. For example, in APML we are using just ATRA, or in certain very bad prognostic AML we give bone marrow transplant, or we use immunotherapy. Either of them, these are first the induction therapy. Okay. So whatever treatment you are given, it is given in phases. The first phase is the induction phase. Okay. And remember, approximately 60 to 80% of the patients will show clinical remission after induction phase of therapy. Okay. Now remember, even after the clinical remission, okay, the patient is showing no signs and symptom of the disease, but when you measure the tumor cells with a sensitive technique, okay, you will find very few surviving cancer cells or leukemic cells, and those cancer cells are responsible for relapse, and that is why it becomes important to measure MRD. Okay, just to give you an example over here to make you understand the concept of MRD. Okay, so after induction phase, the patient has got clinical remission. After induction phase comes many other phases like intensification or consolidation, means addition of new drug, or maintenance therapy. Okay. Now you have to understand, right now we are using the term clinical remission or complete remission. So what is the meaning of clinical remission? So the National Cancer Institute has given a definition of clinical remission. So for AML, what is regarded as a complete remission or a clinical remission? When the neutrophil count is at least 1500 cells per cubic millimeter, or 1.5 into 10 to the power of 9 per liter. When the platelet count is more than 1 lakh per cubic millimeter, or more than 110 to the power of 9 per liter. When the bone marrow aspirate and bone marrow biopsy shows at least 20% cellularity with less than 5% blast. When there is no OR-ROD, when there is absence of extramedullary leukemia, and all these features, all these parameters, they should be sustained for at least 4 weeks or until the initiation of intensification treatment, if the intensification treatment is started in less than 4 weeks time. If the bone marrow blast is between 5 to 25%, then we call it as a partial remission. We call it as a partial remission. So this is the definition of complete or clinical remission for AML. For ALL, if you see, the absolute neutrophil count should be more than 500 cells per cubic millimeter. Platelet count should be more than 1 lakh per cubic millimeter. There should be a normocellular bone marrow with less than 5% blast. There is no lymphoblast in the peripheral blood smear. Absence of extramedullary disease. Attainment of CNS remission and attainment of CNS remission. This is the definition of complete or clinical remission in case of ALL. This is the guideline given by the National Cancer Institute. Okay. Now, what are the methods of MRD detection that you have to know? So, we are having the traditional morphological method, conventional cytogenetics, that is karyotyping, then fluorescent FISH is there, fluorescent in situ hybridization. Then we have immunophenotyping by flow cytometry FCM, molecular techniques, that is the genetic testing, which is far more superior in terms of sensitivity, like the PCR. PCR can be of various types. Most commonly you carry out quantitative PCR, RQ-PCR is very important, and we have next generation sequences also called as NGS. Other advanced techniques, example liquid biopsy and digital PCR are also there. So these are some of the latest methods of MRD detection. Okay. So we are going to discuss each and every method in detail. So initially we are having the traditional morphological method. So traditional bone marrow morphological examination, which is done by cytological evaluation or morphological HPE evaluation or cytochemical evaluation, wherein if you see, complete remission is defined as having less than 5% blast in the bone marrow. Okay, less than 5% blast in the bone marrow by microscopy, by cytological evaluation or by cytochemical evaluation. The sensitivity for detection of leukemic cell by traditional morphological method is 1 blast among 20 normal cells, which is coming up to 5%. So what is the disadvantage of this traditional morphological method? It has a very low sensitivity. Okay. Secondly, following chemotherapy, the blast cell distribution inside the bone marrow can become heterogeneous. So suppose if this is a bone marrow, okay, so the blast cell is located over here, and suppose you have taken the sample from this location, then in that case it might be false negative. The MRD can be false negative. You can falsely label the person as MRD negative. Okay, it cannot measure the MRD accurately, and therefore, if for example, if you overdiagnose the MRD, then you can give if you overdiagnose it, then you can give over treatment, more treatment to the patient. If you fail to detect MRD, then you can give under treatment to the patient. So since MRD cannot be accurately measured by the traditional morphological method, it is no longer used. It is the least sensitive method. Then comes the conventional cytogenetics, that is the karyotyping. Okay, it is a classical method to detect chromosomal aberrations in bone marrow and peripheral blood. So it is used for detecting chromosomal aberrations. For example, BCR-ABL aberration in case of either AML or in case of CML as well. Even in certain ALL, they are having BCR-ABL fusion transcripts. It focuses on detection of chromosomal abnormality both during diagnosis as well as during treatment. The sensitivity is to the tune of 10 to the power of -1 to 10 to the power of -2. Okay, it is widely used and it is a standardized technique. The patients showing early chromosomal abnormality shows correlation between achieving morphological clinical remission and disappearance of these abnormal karyotypes. What is the meaning? I will tell you. So suppose there is a patient of CML. So they will show a chromosomal aberration, that is translocation. Okay, 911 will be seen. Okay, so basically the CML patients are showing this BCR-ABL fusion gene. BCR-ABL fusion gene. So this particular fusion transcript, okay, if it is detected very early in the disease process, so after receiving any kind of treatment, okay, the patient is receiving treatment, okay, when the patient is showing clinical remission, at that time this is also disappearing from the bone, from the bone marrow and from the blood. So that is correlating. So patients who are showing early chromosomal abnormality or presence of this, they show correlation between achieving morphological complete remission and disappearance of these abnormal karyotypes from the blood and bone marrow. So what is the disadvantage of this cytogenetics? The sensitivity is quite low. So it is not as low as the traditional morphological method, but it is bit low. It is bit low. So the only advantage is that along with MRD detection, they are also good for diagnostic purpose for detection of the chromosomal abnormality. Okay, so the sensitivity is low. Therefore, at least 2 to 5% cells are required to to have cytogenetic abnormality or to detect the cytogenetic abnormality. It can only assess the cells during the metaphase period or during the dividing period, thus making the process very time consuming and labor consuming, and it requires expertise as well. So there is a slower reporting time with conventional cytogenetics, and it also requires pre-existing abnormal karyotype to be used as a reference for detecting the abnormal chromosomal anomaly. Okay, so this is about the conventional cytogenetics or the karyotyping. Next comes the FISH. Now what is FISH? It is again a type of cytogenetic method only. So FISH uses specific fluorescent labeled DNA probes to bind with specific DNA target sequence, thus helping in localizing the chromosomal or genetic abnormality within the cell. The sensitivity is again much like karyotyping, but a bit better as compared to karyotyping, to the tune 10 to the power of -2 to 10 to the power of -3. So what are the advantages over the conventional karyotyping? So over here, unlike the conventional karyotyping where you required the cells in the dividing metaphase was required, so it made the process very laborious. Over here, dividing cells are not required. FISH can be performed on interphase nucleus, very big advantage. Secondly, larger number of cells can be analyzed over a short period of time. So there is a faster reporting time, and it can be used for quantifying cytogenetic abnormalities as well. So they are used for quantifying. So over here, conventional can detect, but they cannot quantify. FISH can help in quantifying as well. So what is the disadvantage? One of the disadvantages, even if you see that the sensitivity is a bit better as compared to conventional cytogenetics, but this is not enough for clinical MRD monitoring. Okay, it is not enough. So the disadvantages including, though dividing cells are not needed, yet it is a labor intensive technique. Secondly, it requires a pre-existing abnormal karyotype as a reference, just like your conventional cytogenetics. Thirdly, as I told you, sensitivity, though it is better than the conventional cytogenetics, it is quite low and inadequate to meet the clinical needs. So with higher level FISH, like with polychromatic FISH, it has improved sensitivity, but it is very expensive due to the increased cost of fluorescent labeled probes. Other methods of increasing sensitivity in FISH is to use DFISH or interphase FISH or hypermetaphase FISH. Okay, but all these processes are very costly. So I hope this is clear. The concept of use of FISH for MRD detection is clear. The next important method is immunophenotyping by using flow cytometry. Now, this is basically working on the principle of identifying and quantification of various protein antigen expression on cell surface or cytoplasm by measuring binding of fluorescent labeled antibodies. I will repeat once again. It is now all these process, flow cytometry, FISH, everything has been covered in details in our lecture, okay, in our course of molecular pathology. In the course of molecular pathology, we have already discussed in details about this. So we are just going into the basics of principle, because in the exam you will not have so much time to write each and everything in detail. So we are just in one line, you have to write the principle. So FCM, immunophenotyping by flow cytometry, is working on the principle of identifying and quantifying various protein expression, that is the antigen expression on the cell surface as well as on the cell cytoplasm by measuring binding of fluorescent labeled antibody directed against those antigens present on the surface of the cell or within the cytoplasm. Okay, so this is the cell. So some antigens are present on cell surface, so some antibodies is going to go and detect them, and some antigens are present within the cytoplasm, so they will go and detect within the cytoplasm. Either they can be nuclear antigens or they can be cytoplasmic antigens. So for MRD detection, IPT can be used by two ways. Number one, MRD detection by flow cytometry can be done in two ways. Number one is detection of leukemia associated immunophenotype, also called as LAPE. Number two, identification of different from normal pattern, DFN. These two words, if you do not write in the exams, you will not get marks. So LAPE and DFN approach by IPT is very important. So LAPE is nothing but leukemia associated immunophenotype. What I mean to say, that the leukemic patients will have a very characteristic immunophenotype, so which is identified in the leukemic patients. Example, expression of mature cell markers by immature cells, okay, or cross lineage antigen expression, example expression of lymphoid markers by myeloblast, or altered level of antigen expression. Okay, suppose certain antigen expression, this much is normal in a normal cell, but in leukemic cells the antigen expression is either is very high or is very low, okay, in comparison to the normal level of antigen expression. So this is how you measure leukemia associated immunophenotype. Second is DFN, identification of different from normal pattern. The cells that cluster at sites where normal cells do not localize are considered as residual leukemic cells or MRD. So one advantage of this DFN approach with versus this LAPE approach. Remember, in LAPE you require a reference immunophenotype to compare. Okay, to compare you require not always, but many times you work with a reference LAPE. Okay, so what is very important over here, via the different from normal pattern, it does not require knowledge of presenting immunophenotype, as fixed antibody panel is used irrespective of baseline IPT of leukemia. This is one advantage of different from normal pattern. With either pattern, flow cytometry, okay, using either LAPE or using your DFN approach, they operate by identifying these abnormal immunophenotypes that are characteristic of leukemia cells. Okay. Now, one thing is, while you are conducting the flow cytometry, if there is a reference to initial LAPE is available, then that particular specific antibody which is directed at identifying this immunophenotype will be used. So over here, specific antibody panel can be used for detection of that immunophenotype. Suppose initial reference is not present, in that case you have to use a broad panel of antibody so that you can detect that abnormal leukemia associated immunophenotype. So what is the advantage of this flow cytometry? It is highly sensitive to the tune of 10 to the power of -4 to 10 to the power of -5. Such high level of sensitivity is very much applicable to clinical detection of MRD. Okay, practically speaking. So there is a rapid immunophenotype analysis and rapid reporting. So it is very fast reporting with IPT. Wide applicability is there across various fields, and it is relatively inexpensive. It is relatively inexpensive. What are the disadvantages? Disadvantage is that, now suppose I will give you one example. Suppose this is a leukemic patient. Okay, this is a leukemic cell, or you see this, suppose this is the kind of pattern. This is the kind of pattern, for example, that you see. Okay, this is a leukemia associated pattern that you see, LAPE pattern that you see before treatment, before induction therapy, you see this pattern. Okay, but for example, after the patient has received induction therapy, okay, the pattern became different. Instead of this earlier pattern, there is a bit of change. Okay, the immunophenotype changed. Okay, so what happened, that initially this was the reference pattern, but now after treatment there was a clonal evolution. There was a clonal evolution. As a result, the LAPE, which was the leukemia associated immunophenotype before treatment, was this, but after treatment the leukemia associated phenotype changed. So as a result, what happened? As a result, if you use the same, if you use this as a reference, then you will miss this particular pattern. Okay. So disadvantage is that leukemia associated phenotype before and after treatment may be different due to the clonal evolution. So if you are only using this as a reference marker, okay, that the LAPE at the time of diagnosis, if you use as a reference marker, then it will lead to inaccurate MRD detection. So you have to keep in mind that this might not be the same. After treatment, you have to look for certain other leukemia associated immunophenotype or patterns. Okay, so that you do not miss out and there is no false negativity. Again, you require, the second disadvantage is increased number of viable cells are required. Large samples are burdensome for the patient. So because viable cells are required, you require a lot of samples, and therefore the samples should be processed very quickly because you have to maintain the viability of the samples. So viability of the samples has to be maintained and large amount of sample is required. This is the disadvantage of flow cytometry based immunophenotyping. The fifth important technique, very widely used, polymerase chain reaction, and in today's age most commonly you are using the quantitative PCR, that is the real-time quantitative PCR. Real-time PCR is classically used today. It is a molecular technique amplifying specific DNA sequence and exponentially replicating a targeted segment of DNA, allowing generation of millions of copies of that segment from a small initial sample. It is a highly sensitive and highly specific process, so much so it is reaching 10 to the power of -4 to the power of -6. It is highly reliable to detect MRD. Okay, most cases of ALL are monitored and detected via RQ-PCR as well as in AML, though in AML the process of MRD using PCR is a bit challenging. So how does the PCR detect this? Very importantly, the PCR can detect MRD via antigen receptor gene rearrangements, that is by detecting the clonal IgH and T cell receptor gene rearrangement. Okay, now such rearrangement is indicative of clonality, which you will remember, which I have already spoken about in details while we were discussing about the lymph node and lymphoma. So I am not repeating. Also is discussed in chapter number 7 of general pathology, that is neoplasia. I have discussed in details. So I'm not going that how clonality is achieved by cells. So remember, every leukemic cell, they are specific. Suppose if tumor is arising from this tumor cell, okay, so if this is going to divide, this is having a signature VDJ rearrangement having a specific IgH or T cell receptor rearrangement, and whatever number of tumor cells which are coming from this particular cell having this particular rearrangement, okay, they will bear that same signature. So we say that this group of particular tumor cells arising from this cell, they are having this particular gene rearrangement, which is used for detecting this malignant clone or this clonal population. And remember, always malignant tumor cells are showing clonality. Clonality is a signature of neoplasia, neoplastic transformation. So this principle is basically used for detecting the tumor cells. Okay, so PCR can detect the clonality using antigen receptor gene rearrangement. So we are detecting such unique clonal rearrangement. Second is chromosomal translocation. Second is what? Second is your chromosomal translocation, like your translocation 911 or translocation 821 or inversion 16, translocation 1616, translocation 1517. So all these as well as their associated fusion products like translocation 911 will have BCR-ABL fusion transcript. Not only the translocation, but along with that the fusion transcript can also be detected by the PCR as well as the associated mRNA transcripts. So among the various PCR techniques, the one with higher sensitivity for MRD detection as well as quantification is the real-time quantitative PCR. As I told you, it allows for more personalized treatment strategy and risk stratification, because it is not only detecting but it is also giving you the quantification that how much of the MRD is remaining. So with that quantitative analysis, you can stratify the patient into various groups. Now the utility of PCR has been confined to a subset of leukemia cases which harbors a specific chromosomal translocation and fusion gene. It can be used, but it is difficult to apply, but it is more easily used against those set of leukemia for which we are already having a specific chromosomal translocation of fusion gene as a defined diagnostic set. Now tumor specific chromosomal translocations, if you see, what are certain tumor specific chromosomal aberrations that we know of and that we apply. So for the myeloid lineage, we are basically applying this technique for AML. In AML, we are targeting translocation 821, wherein the fusion gene, if you see, is AML1 ETO. Translocation 1616, where the fusion transcript is CBF beta MYH11. Translocation 1517 PML RARA, that is the APML. Translocation 911, we are seeing your MLL AF9. Okay, I made a mistake, 922. Actually, it is not 911. Over here, I have given you example of 911. No, the BCR-ABL is a 922. By mistake, I have said 911. Okay, it is 922 BCR-ABL. Okay, the example that I have given over here, it is basically BCR-ABL example, that is a fusion transcript, the translocation is 922. By mistake, I think I have said 911. Over here, no, it will be 922. By mistake, I have said CML is having 922. Okay. Okay. So basically, what are some of the known alterations? Among AML, we are having translocation 821, translocation 1616, translocation 1517, translocation 911, which is basically harboring MLL AF9 fusion transcript. Similarly, in case of CML, if you see, we are basically targeting the translocation 922, that is a BCR-ABL transcript. Again, in case of in case of lymphoid lineage, in acute lymphoblastic leukemia, among the B cells, we can monitor translocation 922 BCR-ABL, translocation 119 E2A PBX1, translocation 411 MLL AF4, translocation 1719 E2A HFL, and for the T cell, we are monitoring translocation 1114, having ROM to TCR delta, translocation 114, TALI TCR alpha, translocation 1011, HOX11 TCR alpha. Now I know it is very difficult to remember each one of them, but at least you remember these three, at least you remember this, at least among the ALL BCLL you remember this one, that is your translocation 922 BCR-ABL, and this one 411 MLL A4, these two you remember, and over here any one of them you remember for T cell. Okay. Now clonal rearrangement, as I told you, they serve as a highly specific marker for individual B cell and T cell clones. So in B cell leukemias, they are having a classical IGH CDR3 rearrangement, and in T cell leukemia, they are having a classical TCR rearrangement. Now residual tumor cells with clonal rearrangement after receiving the induction treatment, okay, this clonal rearrangement will be used for detecting the residual leukemia cells, that is the MRD, and that is acting as a predictor for relapse. So what are the advantages of PCR? They are having a very high sensitivity. It's not labor intensive as other techniques. It has a much lower cost. Okay. It is not very technically demanding. What are the disadvantages? As I told you, false negative. Suppose this tumor cell, okay, this was clonal, having one particular rearrangement. After receiving treatment, this particular, for example, they were having certain sets of antigens, certain sets of rearrangement was there, they were clonal. Now after receiving treatment, okay, they became oligoclonal. Whatever clonality was there or specific VDJ rearrangement or specific marker that was there, that changed a bit. Along with these three, they developed certain changes. So the clonality changed. We call it as the clonal evolution. So because of the clonal evolution, so whatever reference clonal rearrangement that you were looking at, or whatever chromosomal aberrations that were present initially, after treatment, that clonality might change, that receptor rearrangement might change. Okay, and such clonal evolution is called as oligoclonality. So what will happen, because at diagnosis, okay, I am having this particular clonal, I am working with this particular clonal rearrangement. So this might not be able to detect these leukemia cells which remained after the treatment. So it might, we might have a false negative, this thing. We might get a false negative result. Therefore, how to avoid this? Therefore, when you are detecting MRD, you should use 2 or more independent monoclonal IgG TCR clonal rearrangement marker for MRD detection. You should use many different combinations of markers, okay, after the induction phase in PCR to detect such residual leukemic cells. Second disadvantage is because there is a lot of amplification of the DNA transcript, so the risk of contamination is high. Now, the utility is confined to a subset of leukemia cases which harbor specific chromosomal translocation and fusion genes, as we have seen over here. So we can easily detect them, for which a certain data is available. Something novel or out of this we might not be able to detect initially, okay, with PCR alone. And only one gene can be assessed per assay in case of PCR. So these are the advantages, disadvantages, the method, the different chromosomal aberrations, and how they are detecting the clonality based detection of antigen receptor gene arrangements for detection of MRD. Okay. Now we are going to discuss the next important molecular marker, that is the next generation sequencing. It is a high throughput molecular technique which is capable of simultaneously reading